Hey guys, hope you're well. Welcome back to ST3 Hacks. And today we're going to continue our hip topic and talk about hip dislocations. We're going to get into the pathoanatomy and how you should structure your station. But let's start with the pathoanatomy. So 90% of hip dislocations are posterior, and they're typically dashboard injuries where the hip is flexed and adducted and force travels up through the femur and the femoral head pops out posteriorly. Clinically, the leg is shortened, adducted, and internally rotated. And that description alone should trigger alarm bells when you see a patient. And posterior dislocations come with important associated injuries. So you want to rule out femoral shaft fractures, femoral head fractures, which are called Pipkin injuries, and posterior wall acetabular fractures. As the femoral head is popping out, it can impact into the acetabulum, and loose bodies within the femoroacetabular joint, which matter later because they cause third body wear. Basically, that fragment in the joint causes early arthritis and wear and tear. There are two big complications you must always mention. So first is sciatic nerve injury, especially the peroneal division. And secondly, avascular necrosis of the femoral head caused by traction or disruption to the retinacular vessels which supply the femoral head. Conversely, anterior dislocations are less common, and they happen with hyperextension injuries with external rotation. In this presentation, the leg looks shortened and externally rotated, and you're worried now about femoral nerve and artery injury instead. Radiologically, you should comment on the femoral shaft, the femoral head, the acetabular wall, and loss of Shenton's line. You should ask for an AP pelvis and lateral of the affected hip, and a CT hip and pelvis is probably necessary here for associated injuries in all traumatic dislocations. So to reiterate, the key concerns here are that the hip requires emergent reduction to reduce the tension on the sciatic nerve and also reduce the risk of AVN. There are no particular guidelines that you need to know for the station. And now let's move on to your triple assessment. So most of these hip dislocations are traumatic, and you want to ensure that you do an ATLS approach to rule out any limb or life-threatening injury. You then want to continue your triple assessment with a history, asking for the time and mechanism of injury, a relevant ample and social history, any previous surgeries, any previous dislocations, especially if they've had hip surgery before, smoking status, and any other past medical history. Moving on to the examination, you should say that I'd use a look, feel, and move approach and prioritize neurovascular assessment. And then be specific. This makes you stand out. So if they've presented with a posterior dislocation, you should explicitly say that you document sciatic nerve function by checking ankle dorsiflexion, plantar flexion, and sensation, and distal pulses. For anterior dislocation, you should mention femoral nerve and artery assessment. This is where the interviews are checking whether you understand what truly might get injured with the pathology that the patient's presented with. Investigations are standard, so I'd arrange an AP pelvis and lateral hip immediately, followed by a CT of the hip and pelvis once the hip is reduced. Importantly, reduction should not be delayed for a CT unless they've already had it in a trauma series. Moving on to management. So you want to say that you make the patient kneel by mouth. I'd attempt a reduction with an appropriately trained colleague to give the patient adequate sedation and analgesia, monitoring, and muscle relaxants. Then I would use the Alice maneuver or the Captain Morgan technique, where you reduce via principles of traction and countertraction. You can read and watch videos on both of them, but the one I chose for my interview was Alice maneuver. So here you need an assistant who stabilizes the ACIS bilaterally. The affected hip and knee are flexed to 90 degrees. You give longitudinal traction in the direction of the long axis of the femur, and then you adduct and internally rotate if required. You then reassess and document neurovascular status, and you check leg length and request repeat imaging. Then you place an abduction pillow or a plus or minus a cricket pad splint, basically stops the hip internally rotating and therefore risking posterior dislocation again. If this fails, I'd inform my consultant and plan to keep the patient on the trauma list for tomorrow. Follow-up. So patients with native hip dislocation should be followed up in a clinic for at least 2 years, as they may develop avascular necrosis, and complications post a hip dislocation include post-traumatic arthritis, femoral head osteonecrosis, sciatic nerve injury or femoral nerve injury, and recurrent dislocations. Now that's kind of the traditional trauma case with a hip dislocation. They can throw you off with other combinations of hip dislocations. So they can have an elective patient on the ward with total hip arthroplasty done recently and they've had a fall. And in this, they're kind of wanting you to use your CCRIS protocol and go in a structured manner to ensure you're not jumping to reduce the hip. But you've done a CCRISP, you've done an A to E, you check their past medical history, their operative notes, You've checked out for any other problems in their chest. Have they got a septic joint? Have they got a wound infection, etc., etc.? They can also make it a prosthetic joint infection with a total hip arthroplasty, and we'll talk about that later when I do my prosthetic joint infection case in the knee section. But yeah, I hope that covers all of hip dislocations, and I wish you well in your revision. I'll catch you in the next one.